Welcome to today's webinar. Really happy to have you all in attendance. We have 112 people on, which is awesome. We're so happy to have you all here. So today's webinar is titled An Introduction to Syphilis and Congenital Syphilis. It is a CityMatCH webinar co-hosted in collaboration with the Task Force for the Elimination of Perinatal HIV. And I wanted to just give a few housekeeping items before we get started, all the usuals. Firstly, this is the first webinar in a series that we are going to be doing on syphilis and congenital syphilis. So this one will really focus on more of a 101 style, really getting everyone acclimated and on the same level with a basic level of understanding. And then we are planning to have another webinar in the near future that will focus more on strategies being implemented at the local level for prevention and treatment of syphilis and congenital syphilis. So stay tuned for that. We'll be sending out that invite once it's scheduled and ready to go. And we hope that you all will continue to join us on this series and continue to learn more with us. And if you would like to learn more about CityMatCH's perinatal HIV and congenital syphilis prevention work, or the Task Force for the Prevention of Perinatal HIV and the wonderful work they are all doing, you can feel free to reach out to me, and I'm happy to get you connected if this is work that you would like to be involved with or work that you would like to just know a little bit more about. We know that syphilis, congenital syphilis is on the rise everywhere. And it might be a topic a lot of you are not familiar with, especially if you are maybe a CityMatCH member, you work in MCH, sometimes these topics are really siloed. So we are happy to have you here and happy to have you joining in. Let's see. The other housekeeping items, I don't think it'll be an issue with the webinar, but if it is, just making sure everyone stays muted. There is the Q&A function for the webinar. So if you have questions during anyone's presentations, you can feel free to use that function and I will facilitate a Q&A. And then let's see, there will be time at the end of the call for questions and discussion. We will be sending a post-webinar evaluation, so please keep an eye out for that. Your feedback is really important to make sure that we're providing meaningful content. And then the webinar will be recorded and posted after. Give us a few business days to be able to get that loaded, but we will send that out after with the post-webinar evaluation. And if there's any connections you would like made with the speakers, I think they'll probably provide their contact information. But if you don't, you're not quick enough to write that down, you can reach out to me and I'm happy to connect you with any questions you might have. And then let's see, while we're working on making sure we get Fanta back logged in, I will just give a quick overview of what we'll be talking about today. So today's webinar will cover the basics of syphilis and congenital syphilis. It will cover the congenital syphilis rates and trends in the US, and then the current landscape of opportunities to address congenital syphilis. We have three really wonderful speakers with us today from the CDC. And while we work on getting the last speaker logged in, I'm hoping the other two speakers can give us a brief introduction of themselves, their work, and a little bit about what they're going to share with us today.
Sounds great. We'll just go ahead and get started without our fearless leader, Fanta Dramé, who I believe will join in a minute. When you guys see her get added, just let me know and I'll stop doing my very best to cover for her, which is never quite good enough. But my name is Kate Mealy. I'm an obstetrician gynecologist, and I am a medical officer at CDC. And I'm also joined by Fanta Dramé, who's one of our health scientists, and by Dr. Phoebe Thorpe, who's a pediatrician and senior medical officer at CDC. And we're thrilled to have this time and really appreciate everyone really caring about syphilis at all. So we are incredibly grateful to each of you for your support. We have no official disclosures, and these findings and conclusions that we're presenting are those of ourselves and not necessarily of our institution. I will mention, just for context, as we get started in this conversation, that it's important to remember the deep-seated mistrust around syphilis, in particular of the public health and general healthcare community, in the context of the U.S. Public Health Service syphilis study at Tuskegee, which was conducted from 1932 all the way until 1972 to follow the course of untreated syphilis. And of course, participants were not consented, and nor was treatment offered even after it was widely available. And this study has had long-reaching impacts on our overall healthcare in the United States, and in particular in regards to syphilis. We have to remember the people whose human rights were violated and the generations of people whose lives were impacted and continue to be impacted. And with that in mind, I also would like to offer a language disclaimer and remind everyone that race and ethnicity, while we are going to discuss them and while they are real, are social and not biologic constructs. Any differences that we see in our data should be interpreted not as due to a biologic cause, but rather as a result of systemic racism and implicit bias. We do our best to use the terminology of pregnant person and birthing parent throughout to discuss people who are or have been pregnant. And at times where the adjective maternal is used, it should be understood to be representative of the birthing parent, agnostic to gender or gender identity. We are going to try to use our polling software. So if everyone can go ahead and give this a go, you can join anonymously. You do not have to put in your name, which is why I love this platform, by either going to this web address, either on your computer or on your phone, or you can send a text message to this number. And it will be at the top of each of our polling slide questions. So if you aren't able to join in this exact moment in time, you'll see that information in a minute.
Hey, Kate, can you hear me?
Yeah.
Okay, so I just can't, I'm not on camera, but I'm here.
Oh, go for it. Oh, you take over this part. Go, please. I hate this.
Hi, everyone. Well, welcome. Thank you, Kate, for jumping in and introducing me. So my name is Fanta Drame. I'm a public health advisor within CDC at the Division of STD Prevention. And as Kate mentioned, we're going to have a couple poll questions throughout this presentation. So feel free to join by web or join by text. And if you're having trouble or difficulties accessing this, feel free to drop in your answers in the chat function. I believe should be working for people, Reagan, if I'm not mistaken, or if not, just try to get access to the poll everywhere. So that's pollev.com/RawMcDonald667, or you can join by text by sending RawMcDonald667 to the number 37607. And then once you get to the responses, then you can type in either your response to the question there. Okay, so we just move on to the next slide. So the first question, we just want to get to know who's in the room. So please drop in like, what is your position, your role, your title, and your current space. Right, so we got a couple epidemiologists, health managers, nurses, practitioners, directors, consultants. Okay. All right, so now that we know who our audience is and who we'll be communicating with, so yeah, we'll be able to answer your questions and tailor this presentation to you. So I'll pass it over to Kate to go over the syphilis and congenital syphilis basics in 101.
Sounds great. Thanks so much, Fanta.
Mm-hmm.
As I mentioned before, I'm not as good at driving the slide deck as Fanta is, so please forgive me. So we're just going to go through the basics of syphilis and congenital syphilis. Because this is a sexually transmitted infection talk, it does have clinical images of genitalia, so just you've been warned. And this is just, again, a brief overview, but we just wanted to get a sense of kind of what you guys are thinking about syphilis and how aware you are of what's happening in the syphilis sphere. It looks like most folks are either somewhat familiar or very familiar, which is great. And so we're going to kind of fill in some of those details about what syphilis is exactly. And then Phoebe will go through the numbers and Fanta will tell us where our challenges and opportunities are. Thanks, everybody. So just as a reminder, I know you know most of this, but we just thought we'd level set a little bit. So syphilis is a sexually transmitted infection. It's caused by the spirochete bacterium Treponema pallidum. It can lead to serious health problems without treatment, which is why we're all here today. Infection develops in stages: primary, secondary, latent, and tertiary, and each stage can have different signs and symptoms. Of course, syphilis can be transmitted by direct contact with a syphilitic lesion during vaginal, anal, or oral sex, and then transplacentally to the fetus. Very rarely is it transmitted through touching infectious lesions or through blood. And those big complications that I mentioned. So mostly when we think about syphilis, when we remember it from when we were in school, we think about neurosyphilis, eye syphilis, and ear syphilis that cause things like stroke and meningitis, blindness, and hearing loss. But the reason that we are all gathered here today is because of the consequences related to congenital syphilis, which is that transplacental transmission. And that's associated with miscarriage, stillbirth, and neonatal death. And I'll just mention before we get to Phoebe's review of the numbers, that none of our numbers involve miscarriage numbers. And I think we in the CityMatCH community are all very much aware of the impact of miscarriage on people and people's lives. So just remember as we're looking at the numbers that these don't even include syphilis-related miscarriages, which I think is really important for me to think about as an obstetrician gynecologist. And then, of course, the other thing that we're all aware of is that syphilis does cause increased HIV acquisition and transmission, which is pretty terrifying to think about in the context of our current numbers. I'm going to go through the syphilis stages in a minute. They are frankly very overwhelming, and every time I review them, I feel very apologetic to my audience. For the record, I did not make the syphilis stages, and I'm sorry that they exist in this complicated fashion. The three important takeaways are that syphilis goes through several stages. Clinical stages and surveillance definitions are different from each other, which also adds another layer of fun. And neurosyphilis, ear syphilis, and eye syphilis can occur at any time during syphilitic infections. So this is the basic outline for the syphilis clinical stages: primary, secondary, latent, and tertiary. One caveat that I will mention is that while syphilis stages usually progress linearly along the slide from the left to the right, sometimes it can go out of order or in reverse, in particular in people who are living with HIV. So this is our first slide on primary syphilis. So primary syphilis usually appears about 3 weeks after the initial infectious exposure. And the thing that makes syphilis really amazing is that the syphilitic sore, that's called a chancre, or it's also known as an ulcer, goes away even if the person does not have treatment. So on the lower left, you see your kind of classic penile chancre, which is what I always saw in my textbooks. And then as a gynecologist, I didn't know what I was looking for. But then in recent years, we've become more familiar with chancres on the female genital anatomy. As you can see in the second picture here, this is a labial chancre. And the third picture is a chancre on the tongue. And then the last picture is what's known as a kissing lesion. And so as you can see, there are 3 separate lesions here, which is different from the kind of classic single penile chancre. And the reason that this can happen is either there's multiple sites of infection, or when the tissue folds on itself, it can spread from one site to another. And then the other thing I'll mention is that very classically, as it says here on the slide, that chancre is painless. But in recent years in particular, we've seen increasing numbers of painful chancres. And that's for a variety of reasons. And one of the most significant is because often people who have syphilis can be co-infected with herpes. And then these ulcers can become very painful. And the other thing I'll mention is that because these lesions can be painless and because they can occur in locations that patients cannot see, someone might not even ever know that they had a chancre, which makes everything more exciting for us as syphilologists. Now we're going to talk about secondary syphilis. So secondary syphilis usually occurs 3 to 6 weeks after primary syphilis. And again, like primary syphilis, these symptoms will go away even without treatment. Most commonly, secondary syphilis is associated with rash, lymphadenopathy, fever, and fatigue. We also see things like headache, alopecia, which is hair loss, mucocutaneous lesions, and these lesions on the genitalia called condyloma lata. I will mention that often the rash of secondary syphilis can be as subtle as the one in the lower left here on this slide. And classically, the rash of secondary syphilis includes this rash like what you see here on the sole of the foot or on the palms of the hands. But not having one of these classic secondary syphilis rashes does not mean that someone does not have secondary syphilis. And then syphilis will usually go into a latent period. And of course, a latent stage of syphilis is when there are no visible signs or symptoms. And without treatment, someone can continue to have syphilis in their body for years. We divide latent syphilis into two categories: early latent, which is less than 1 year since infection, and late latent, which is more than 1 year since infection. And then because it can often be difficult to tease out how long someone has had latent syphilis, we often end up putting them into a category of latent syphilis of unknown duration, which is a little dissatisfying as a diagnostician, but that's what we have. And then this is tertiary syphilis. And so this is what we often kind of have heard about in historical information from throughout the world about syphilis. And so tertiary syphilis is your classic impact on different organ systems, mainly including the heart and blood vessels, as well as the brain and the nervous system. You can get these skin lesions that are known as gummas. And if you go back to and look at like old pictures from Victorian era, you'll see people wearing these weird nose things that go overneath their noses or over other areas of their body to cover up these gummas. It's kind of very fascinating if you Google it. Usually tertiary syphilis occurs about 10 to 30 years after an infection begins. And then, we often group, our nomenclature is so confusing, I'm sorry. So I'm just going to go over it briefly. So we often group primary, secondary, and early latent syphilis together, and we call them early syphilis. And these are really the leading edge of the syphilis epidemic because these are the most infectious stages. There's also the greatest potential for vertical transmission to the fetus. And they also are all grouped together with our treatment regimens, which is important for us to think about, and we'll talk about that next time we talk. And then we group, let's drive ahead, and then we group late latent syphilis and latent of unknown duration and tertiary syphilis together as late syphilis. And these are less infectious, and they're also grouped together by treatment regimens. And then just as a reminder, I said this before, but this is such an important point, is that neurosyphilis, eye syphilis, and ear syphilis can occur at any stage of syphilitic infections. And this is something that I worry about a lot every time I diagnose someone with syphilis, is thinking about whether they have any symptoms that might be reflective of one of these. Okay, let's see. This looks the same as the last one, so I'm gonna move ahead. All right, so we're going to talk about congenital syphilis. So congenital syphilis is an infection with Treponema pallidum acquired in a fetus when a pregnant person is not treated or is inadequately treated for syphilis. And like I mentioned before, syphilis during pregnancy is associated with miscarriages, stillbirths, preterm delivery, and then perinatal mortality. And then early congenital syphilis is when syphilis occurs in a kiddo who's under the age of 2. And as you know, and we'll talk about that in a minute, is that if left untreated, congenital syphilis can have very serious complications. That said, when most babies are born with congenital syphilis, they do not have any symptoms. Sometimes they will present with or eventually develop a big liver or jaundice or rash or snuffles, which is this kind of drippy goop from the nose that you can see in this picture, or bone abnormalities. But if treated, these neonates should not have issues. However, late congenital syphilis is syphilis that occurs in kiddos and is diagnosed after the age of 2. And these are the really serious lifelong consequences that we think about. Very classically, this is the Hutchinson's triad, which involves complications with the eyes, often leading to blindness or at least partial blindness, deafness, or complications with the teeth. This is those classic kind of Hutchinson's teeth or mulberry molars, if you've heard of those before. And then late congenital syphilis is also associated with skull abnormalities, including a saddle nose, frontal bossing, changes in the long bones, like the shins, and developmental delay. But I think the most important slide of this entire talk is this one, because congenital syphilis can be prevented by diagnosing and treating syphilis prior to pregnancy or diagnosing and treating at least 30 days before delivery. And now I'm going to turn it over to Dr. Phoebe Thorpe, who's going to talk us through the numbers, which are frankly pretty terrifying, don't you think, Phoebe?
Yes, can you hear me? Thank you, Kate. I'm Dr. Phoebe Thorpe, and today I'll be talking about current trends in syphilis and congenital syphilis. As Kate described, syphilis presents in stages, and we collect information about the stages. But since primary and secondary syphilis are associated with the most recent infection, we use them to figure out where the disease is spreading. Here, the lighter the color in the map on the left, the lower the rate. The darker or the bluer the color, the higher the rate. And you can see when you look from left, the 2013 to 2022, rates are increasing, and they're increasing everywhere in all parts of the United States, especially in the southern and western areas. There are also differences by race and ethnicity. Non-Hispanic American Indian and Alaska Native persons and Black American, African American persons had the highest rates of primary and secondary syphilis. And since 2018, the American Indian and Alaska Native persons also have had the greatest 5-year increase, almost over 300% since 2018. And while historically men have had a higher rate of syphilis, during 2020 to 2022, the rate of primary and secondary syphilis among women increased 190% compared to only 44% among men. And over the span of a decade, the rate among women has increased by more than 860%. And these increases in syphilis, especially among women, is concerning for congenital syphilis. This slide shows the striking relationship between primary and secondary syphilis in women of reproductive age, and shown in the black line, and the increases in congenital syphilis shown in the blue bars. During 2020 to 2022, so just 2 years, there was a 73% increase in CS cases. And if you look over the last 10 years, there's been almost 1,000% increase in congenital syphilis. And this map, like the previous one, helps show where this is occurring. Similarly, the lighter colors show less cases, and the darker colors show more. In the span of just a decade, we've had congenital syphilis increase all across the country. And while there were only 362 cases in 2013, which is 362 cases too many, there were over 3,750 cases in 2022. Congenital syphilis, as Kate has mentioned, has many health consequences, and unfortunately that includes infant deaths and stillbirths. Globally, congenital syphilis is the second leading cause of preventable stillbirths. From 2013 to 2022, congenital syphilis-related stillbirths and infant deaths have increased over the last decade, with 51 infant deaths and 231 stillbirths reported in 2022. This slide shows both the rates of congenital syphilis by the length of the bar and the number of cases on or next to the bars by race and ethnicity. The highest number of reported cases was among those who are non-Hispanic, Black, or African American, highlighted by the gold box, followed by the Hispanic and Latino and non-Hispanic white. This is the same graph, but shifted to the rates of congenital syphilis in 2022, which were highest among those who were non-Hispanic, American Indian, or Alaska Native, followed by the non-Hispanic, Native Hawaiian, or other Pacific Islander rates, and those who were non-Hispanic, Black, or African American. When using rates, it can be challenging to grasp the significance of the rates and the gravity of the disparities of congenital syphilis among certain racial and ethnic groups. This is the same data showing congenital syphilis cases per live birth for 2022 on the right-hand side of the slide. For American Indian and Alaska Native birthing parents, there was 1 case of congenital syphilis for every 155 live births. In contrast, for Asian birthing parents, here it's shown that there was 1 case of congenital syphilis for every 9,588 live births. This is a profound difference. And what's so troubling about these increases in congenital syphilis is that every case is preventable. My colleagues have analyzed the data looking for timely testing and treatment during pregnancy and where there are gaps. And almost 90% of the 3,755 cases in 2022 could have been prevented with timely testing and treatment. And now I'm going to turn the presentation over to Fanta Drame, who will discuss ways we can increase access to prenatal care and overcome some of the challenges that women and their families face when accessing that care.
Yes, thank you, Phoebe, and thanks, Kate. So before we get into challenges, we just want to get a sense of what challenges do your communities face in accessing prenatal care and syphilis testing and treatment. And for those of you who joined late, we have a couple of poll questions, so that information is up at the top for you to join and add in your responses. So we'll just pause for a few seconds for people to add their responses in. And let me make sure the link is live. Oh, it is live. Okay. And so we know that the chat feature is not open, so we're just collecting everybody's responses and thoughts here. Sorry about that. Transportation, rural, lack of access to care, not getting timely testing and treatment, poverty. Yes. So these are great. These are some of the challenges that we're going to cover in the next section. I'll just give it a few more seconds for people to add in a response. Language barriers, that's great. Cost, being unaware, lack of education. Yep. Yep. Okay. So you guys touched on a lot of the challenges that we'll speak about today. Next slide. So give me 1 second. So just like many other public health challenges, the underlying systems of systematic barriers and institutionalized racism have significantly contributed to the increases and disparities in congenital syphilis rates. These systems often result in unequal access to quality care, comprehensive sex education, and resources and tools for prevention, ultimately disproportionately affecting marginalized communities. It also leads to competing priorities of basic needs. So for example, someone who's experiencing homelessness may prioritize finding shelter and food over getting routine screenings compared to someone who doesn't have to make this constant decision every day. Additionally, as Kate mentioned earlier, the historical mistrust in the healthcare system stemming from traumatic events such as the Tuskegee experiment is also crucial to recognize because it can deter people from seeking timely testing and treatment for syphilis and other primary healthcare services. So overall, when we talk about addressing congenital syphilis, it's not merely about treating cases, but also dismantling the inequitable systems and rebuilding the public's trust within the healthcare system to ensure that everybody have access to routine care services, which includes syphilis screening. Next slide, please. Substance use also presents a significant challenge in addressing congenital syphilis. In 2022, approximately 12% of primary and secondary syphilis cases reported methamphetamine use, followed by 7% reported injection drug use. And between 2018 and 2022, so that 4-year time frame, there was a 2% increase in cases for both injection drug use as well as methamphetamine use. And keep in mind that these are self-reported measures, and we know that people don't often disclose substance use. So this probably isn't a full picture of the intersection between substance use and syphilis. And then this is important. Oh, sorry, back 1 slide. So this is important because substance use during pregnancy has major implications for congenital syphilis. A recent publication examined substance use among pregnant individuals diagnosed with syphilis in Arizona and Georgia. It revealed that the prevalence of substance use among pregnant individuals with syphilis was nearly twice as high with those who had a CS outcome compared to those who didn't have a CS outcome. Additionally, half of those individuals who use substances and had a CS outcome received late or no prenatal care, underscoring the complex relationship between substance use, prenatal care, and congenital syphilis. Next slide. So one factor that plays into this are the punitive policies for substance use during pregnancy. This is a policy wheel that provides a visual overview of the punitive policies that's shown in orange and brown, and the supportive policies shown in green for substance use during pregnancy by state. So overall, since the 2000s, there has been a larger increase in punitive policies nationally compared to treatment supportive policies, and these punitive policies affect access to adequate prenatal care. Next slide, please. Another challenge is pregnancy care deserts, which further complicates access to prenatal care. Pregnancy care deserts are places that lack maternity care resources, meaning there are no hospitals or clinics offering obstetric care. This figure is taken from the March of Dimes report on maternity care, showing a geographical distribution by county of access to care. So it's showing that more than 2.2 million women live in pregnancy care deserts. So if there's no access to obstetric care, that means people are not getting prenatal care. And more likely, if they're not getting prenatal care, they're not getting access to comprehensive care and screenings during their pregnancy, which includes syphilis testing. Next slide, please. Also, in general, there's a question of where people are getting care. National case-based surveillance data show that most people are getting screened outside of STD clinics for both men and women, and that proportion is growing compared to people being tested at STD clinics. This has major implications for testing and treatment because if people are not going to the clinics, we need to bring syphilis testing and treatment to them, essentially meeting populations where they are. And we'll talk about this in a few slides later on in the presentation. And then finally, another challenge that we're facing right now is the biostimulant shortage. And the biostimulant shortage that we have been experiencing nationally impacts care for persons with syphilis and is especially concerning since penicillin is the only option for pregnant persons. So this has cross-cutting effects because especially with doxycycline, which is our ultimate regimen or ultimate treatment, it's much harder to adhere to because as opposed to like a single shot or 3 shots with penicillin, depending on the infection stage, doxycycline requires you to take it orally twice a day for 14 days. So it's much harder to adhere to. And all of this to say is that we know that syphilis is hard. It's pretty complex because syphilis presents significant challenges in testing, staging, and treatment that just as Kay has shown earlier. And due to its complex nature, its variability in symptoms, and also it's known as the great imitator because it can mimic a lot of other diseases. However, that does not mean it's preventable. Just a fun fact for you guys, it is the second leading cause of preventable stillbirths worldwide after malaria. So with that being said, it is preventable, but with strategic collaborative partnerships and education, we can hope to alleviate some of the barriers that people face and hopefully prevent increases in the future. And then we'll talk about some of those ways that we're addressing congenital syphilis next. Next slide, please. So to address syphilis and congenital syphilis, there are many pieces that need to fall into place. There are 4 main areas of opportunity, in addition to the bigger picture issues like the needs for development of better testing treatment and getting everyone into early and high quality prenatal care. So we're going to go through each of these areas. So first, we need to screen and treat all sexually active people. Since syphilis can be asymptomatic, screening is essential. A person may not know they have syphilis until they are tested. And CDC guidelines have long included increased geographic risk as an indication for screening. Last November, CDC clarified what rate can be used for this geographic risk assessment by using the goal set by Healthy People 2030 for reducing the syphilis rates and reproductive age women to 4.6 per 100,000 or lower than that rate. So this currently includes 46% of the counties or 76% of the US population that's higher than that 4.6 rate out of 100,000. So this essentially suggests that almost everyone should be getting screened for syphilis since it's widespread. And we should be screening anyone with increased risk of infections, which we can only know by taking comprehensive social and sexual health histories. The next area is increasing screening and treatment during pregnancy. So all healthcare during pregnancy is prenatal care, and any pregnancy encounter is an opportunity to screen for syphilis. It's essential that all people who are pregnant get syphilis testing as soon as possible during pregnancy, typically when pregnancy is confirmed or at the first prenatal visit. If loss to follow-up is a concern, we want to consider using rapid syphilis testing and treating at the exact same time. Per ACOG's new guidance, which I'll show in a minute, everyone should be getting screened at 28 weeks gestation and again at delivery, including at that first prenatal visit. Also, no postpartum person or newborn should be discharged without documented syphilis testing during pregnancy and again at delivery if they're considered high risk. and all people with a stillbirth should have documented syphilis testing. Regarding treatment, the only recommended syphilis treatment during pregnancy, as I mentioned before, is benzathine penicillin G. And due to the current shortages, we are prioritizing this medication for people who are pregnant in jurisdictions where it's needed. And it's crucial to test and treat the partners of people who are pregnant. So it's not just okay to just treat the pregnant women. We have to also treat the partners to prevent reinfection. And I'll pass it over to Ashley real quick. Next slide. So this is ACOG's recommendation that I mentioned earlier, and just to read it out loud. So it says OBGYNs and other obstetric care professionals should screen all pregnant individuals serologically for syphilis at the first prenatal care visit, followed by universal rescreening during the 3rd trimester and at birth, rather than using a risk-based approach to testing. So in summary, in order for us to maximize the opportunity of catching syphilis before it becomes a congenital syphilis case, we should be testing women 3 times. So first at the prenatal care visit, at the 3rd trimester, and again at delivery or at birth. And I'll pass it over to Kate real quick to talk about extensiline, which is our treatment for the drug shortage.
Yes. So in the context of having difficulty getting and keeping bicillin in stock, the U.S. federal government figured out how to temporarily import extensiline, which is also benzathine penicillin G, into the United States from France. And extensiline is in the same dose units as bicillin as you see here, except it comes as a powder that with a diluent that must be reconstituted or mixed together before you actually inject it. It's also a whopping injection, as you can see here from the volumes. So that's something to keep in mind. And I will say, you know, our great hope at the federal government was that this would be able to address a lot of the treatment shortage issues, that it has been challenging for folks to figure out how to get it paid for, because not all jurisdictions have applied 340B pricing, if that means anything to you, to this medication in the same way that they were able to do so for bicillin. But that said, both ACOG and the Society for Maternal Fetal Medicine have endorsed extensiline as being an option for people who are pregnant. But the underlying kind of caveat to all of this is that if you have someone who's pregnant and you cannot track down bicillin, you should start by contacting Pfizer, and they should be able to get you a reserve dose that they have on storage for people who are pregnant. And if you have any trouble at all, contact us at CDC and we'll make Pfizer give it to you.
Thanks, Kate.
Yeah.
And then the third area of opportunity is expanding syphilis screening beyond traditional venues. So as I showed a few minutes ago, we showed that surveillance data has revealed that most syphilis cases are identified outside of STD clinics. So it's vital for us to think creatively and implement routine syphilis services in diverse settings, especially where places where people seek care. So that includes jails, emergency departments, urgent care centers, homeless shelters, syringe service programs, maternal child health programs, community centers, and anywhere else where you think people are receiving and seeking care. And then also in settings where there's no phlebotomy or follow-up care is challenging, rapid syphilis testing can help identify and treat syphilis in a single encounter rather than having someone come in for testing and then a couple days or weeks later they come back in for treatment, and that's caused concern for loss of follow-up. Next slide, please. And lastly, the final piece of the puzzle involves education, training, and surveillance, which is why we're here today educating you all. So it's crucial to educate and train not only perinatal healthcare providers, but OBGYNs, the perinatal care nurses, doulas, midwives, community health workers, family care physicians, anyone who's providing care to pregnant women on that pregnancy care continuum. And continuous efforts are needed to raise awareness among the general public about syphilis, its effect, and preventative measures. So just as everyone is aware of HIV and its health consequences, everyone should be informed about syphilis in the same manner. And we always say that prevention begins with education. So if those most affected are unaware, then it hinders our progress tremendously. And our last poll question, before we turn it over into discussion and answer some questions, we want to just ask you guys, what are some innovative approaches or interventions that can be implemented to decrease congenital syphilis in your communities? So thinking about like in the space that you work in, whether it's like your unique role or like you work in a community health center, you're directed to a program, what are some approaches, or it don't have to be new, but what are just some ideas that you think we can implement to decrease congenital syphilis in the communities that you work in. So we want to hear your thoughts. No idea is big or small. It could just be simple as printing out a flyer. It could be big as like setting up a mobile clinic. So we just want to hear all you guys' ideas, just to see. Okay. And we'll just leave this up for a few more seconds for you to add your ideas. Yep, education, outreach, mobile testing, yeah, more awareness. Yeah, I agree. Outreach, okay. Service and nice announcements. Okay. These are all great answers. Keep them coming in. Oh, yes, Phoebe.
I just was wondering, I saw using class resources, CLAS. Wonder if somebody could elaborate on what those were.
I believe they can't come off mute. But if that person could just, I guess, retype their answer with that acronym written out or within the chat function, the Q&A, that would be great. And then now I'll pass it over to Kate to just share some resources for you guys. Thank you.
Sounds good. I was trying to roll back so I can see the question in the chat, but that obviously failed. I'm not as good at driving as Fanta is.
No, you're fine.
But Anna put in the chat over here, culturally and linguistically appropriate services class standards. And then I have a couple questions that we'll answer at the end that I have been watching in the Q&A. So please keep putting them there and we'll get to them. So as Fanta said, you know, we have these new kind of great specific number recommendations about what's considered high prevalence of syphilis. But then of course, the follow-on question is, well, how the heck do I know what the syphilis rate is in my community? And we have this very functional feature on the CDC website that most people don't know about. It's called CDC STI Atlas. And so you can get to it by either using this QRS code, or I just Google CDC STI Atlas, and you can play with a lot of different numbers by county, by state level, looking at all sorts of STIs, by age, by sex, and it can help you understand what's happening in your community. And again, we're recommending increased screening in the context of communities where the primary and secondary syphilis rate among reproductive age women is above that 4.6 per 100,000 population. And then, of course, we have our STI treatment guidelines app that if you haven't yet downloaded it, you should. It's free, and I find it very useful. And then one of the resources that folks outside of the STI community don't know about, but CityMatCH folks probably do, is the National Network of STD Clinical Prevention Training Centers, or the NNPTCs. And they are spread out all across the US, as you can see, and they're a phenomenal resource for STI education. So if you work in a setting where you think your community might benefit from a syphilis talk, you can reach out directly to the NNPTCs, and they'll find someone in your local area who's familiar with your local context who can give that talk. And of course, if you have any trouble, you can just let us know too, and we'll facilitate it. As a piggyback to that, there's also this national STD curriculum that's available for free and has continuing education credits as well through the University of Washington. I learn something every time I do one of these modules. They're about all the STIs. They're really for all levels of learners. I find them very approachable, and you can kind of skip through and pick things that you find most interesting. And then there's the STD CCN, or the STD Clinical Consultation Network, which is also available for free. And if you have a question about specific management of STIs, you can go right to this website, enter your information, and someone will get back to you, usually within 1 or maybe 2 business days. And you know, I love this as an option, especially like if you were to get a message in your clinical in-basket that you don't know how to deal with, you can reach out to them before you get back to your patient. And I will say, one other thing I really like about STD-CCN is that they're not afraid of pregnancy. So if you have a patient who's pregnant, they're happy to take your question, unlike, frankly, most clinical consultation services that I work with. And then Fanta put together this phenomenal syphilis and congenital syphilis resource sheet that summarizes a lot of the things that we've talked about today. And I just wanted to point out the bottom of this sheet, the approaches to addressing congenital syphilis. These are link outs to a lot of really great resources that we don't have time to get into today, including some funding flexibility specifically for Title V clinics that I think might be useful for this audience. And that is it. These are our email addresses. I'm going to leave up this resource handout while we take a few questions. I'm going to start with one that I think it takes a little longer to address, so I couldn't address it in the context of the chat box. So someone asked, is RPR testing considered standard of care during pregnancy? And I will say, actually, lab testing is much more complicated for syphilis than anyone could ever have dreamed of. So when Phoebe and Fanta and I were thinking about this talk, we decided to save the lab testing piece for our next conversation together. And today we are just going to kind of present an overview and go through syphilis staging, which I frankly find confusing enough on its own. But to quickly answer your question, there are two blood tests that we use for syphilis. One is called the traditional algorithm and one is called the reverse algorithm. One starts with an RPR and then one uses an RPR as a confirmatory test. And either are considered appropriate for use during pregnancy, and neither is considered a better option than the other. It just depends on your healthcare system and your lab's capacities. And then the third testing option is that rapid or point of care test that we're going to talk about more when we talk together next time. And that rapid or point of care test, the currently available options in the United States are only treponemal tests, so they don't include an RPR. But we'll talk about that more next time. And then Gina is saying, I think providers need to be educated on syphilis and pregnancy. I mean, I completely agree with you. We're all on the same page. We have been trying our best to do a roadshow around syphilis education at various national meetings and conversations like this to spread the word. And I will say that our professional societies have also been working to push out their own information that's targeted for their specific membership. And one nice thing in the perinatal space is that the Society for Maternal Fetal Medicine is working with ACOG and the Midwifery Society to, I think also the Women's Health Nurse Practitioner Society, to come out with guidance that will be out around management of syphilis during pregnancy, and it should be out by the end of 2024. I just had a reconfirmation of that over the weekend when I presented with the person who's writing it at ACOG, which is the National OBGYN Society meeting. And then, Idaho had a funny thing with their surveillance number this year. So if you're interested specifically in Idaho, if you send me an email at this email address, you can remember it because it's PPH9, postpartum hemorrhage 9 at cdc.gov. I can get you a specific answer about Idaho's data. And then, you know what? I see the notes about the QRS code, Vanessa. I will say CDC did a complete website overhaul on Thursday night of last week, which screwed up some of our links, I bet, which I hadn't thought about, but I bet that's why that is. But if you just Google CDC STI Atlas, you'll get that resource and it should pop right up for you.
And Kate, I think Callie answered another question. So if you go through the answered questions, if you're an attendee, you should see a link that Callie shared that will take you to what was mentioned by Kate for some easy.
Thanks. It's been a real adventure having our whole website updated at the same time in one night.
Oh, I am sure.
Thank you, Callie. What other questions do folks have? Or anything I missed or anything that you think was unclear for my co-presenters or other hosts or panelists? Yes, Valorius, we're working on making things available in Spanish. I'll be honest with you, I don't think that CDC has great materials on syphilis and congenital syphilis quite at this current moment in time, and we're working on updating them. But we had to wait until our website completely rehauled on Thursday night, and so now we're going to be pushing those out, and they will be made available in Spanish as soon as they exist in English in a format that at least I'm happy with. Phoebe, is that a reasonable answer?
Yes, yes, we have had to wait until the website was revamped before we could move forward with the Spanish part. Yeah.
And then Reagan, I'll send you out a PDF of the slide deck and we're happy to send those out.
Perfect. So I will include those for anyone that attended. I'll include that with the recording link as well as the post-webinar evaluation. It'll all come in one email.
And yes, and people who are having trouble accessing the QR code, I put in a bit.ly link. So you should see that in the chat or the Q&A. But we'll send that out as well. Yeah.
Okay, and I see a question just came in. Is there a way we can sign up for other webinars around congenital syphilis? So like I mentioned from CityMatCH's end, we will be having at least one more, probably two more webinars around syphilis, congenital syphilis. And if you received the information about this webinar, you will also receive the invite and the save the date for the next one. But from our CDC speakers, are there any other listservs you recommend getting on where individuals can receive information about learning opportunities around congenital syphilis?
Absolutely. I will say Mother to Baby just did a syphilis webinar, and I will send the link for that recording, which I think would be relevant for this audience, out to Reagan with the slides. And so you'll get the link to that recording. And then on that resource sheet that Fanta has, there are a bunch of other learning resources listed in there. The other one that I think might be really useful to this audience, Phoebe and Fanta, is the National Syphilis and Congenital Syphilis Endemic Task Force webinar on child protective services. And so I'll send that recording out as well, because I think that folds really nicely into how we as maternal child health folks think about the care that we're providing.
We have a few minutes left. Are there any other questions? Feel free to put them into the Q&A feature. And I am kind of curious for myself. I know we have individuals joining from a lot of different sectors. I'm curious for individuals that work in the MCH space, specifically in health departments, if there's a lot of collaboration with your infectious disease STI partners within the health department around congenital syphilis. Is there collaboration happening, or is it kind of still sectored out? And you can chat in your responses if you feel like sharing into the Q&A. Thanks for sharing that, Ron. It's very helpful. Oh, okay, great. I'm seeing some people are working in collaboration. That's awesome to hear. I think that is where we're most effective, but I still see some.
I know that one of the things that we've been trying to do is meet with our SAMHSA colleagues, because they, if you could go back to the resources, Kate, one of the, I'm not sure if you can see it, that the second at the bottom in the blue box where they're talking about approaches to addressing congenital syphilis, in addition to the Title V Dear Colleague letter, the next one down is a Dear Colleague letter from SAMHSA that's encouraging them to spend resources on syphilis screening and testing as part of their treatment facilities for both harm reduction and substance use. And they, we've met with different HHS regions of SAMHSA, and they, once they hear about the problem, many of them are very eager to help, especially since this Dear Colleague letter has come out, and it's very specific about the flexibility that they're providing, and we're grateful. I'm very grateful that SAMHSA's dug in and looked for ways that they can increase the syphilis screening.
Thanks, Phoebe, and thanks everyone for sharing too. I'm reading everyone's responses. It's really interesting to hear how everyone's tackling this in their local jurisdiction. Okay. Well, we are almost at time. I do want to thank everyone for joining. I really do apologize for the rough start. Needless to say, I will not be using the webinar feature in the future. I will stick with Zoom that I somewhat do know better. But thanks for hanging with us. Thanks for your patience. And a special thank you to our three speakers. We're really lucky to be able to learn from all of them today, and we're excited to continue learning with all of you. I hope you will all join our future webinars, and if you're really interested in this work, like I mentioned, please reach out, learn more about what we're doing, and see how you can get involved. If you need to reach out to any of the speakers, Kate, do you want to put up your contact information one more time for folks?
Boom.
Perfect. And if you don't have time to write this down, you don't have a pen, you can reach out to me and I'm happy to do any connection as well. We will leave this up for a few more minutes while any lingering questions get answered. But thank you all for joining and looking forward to continue learning with you all in the future. Have a great rest of your Tuesday.
Yes, thanks so much to everyone for your interest and for the amazing work that you're doing.
Thank you very much. Appreciate it. And please reach out to Kate or myself or Fanta if you have questions.